I'm Dr. Karthik Raj from India. So this is going to be an academic video on spine examination for MCH Edinburgh purposes. Here's Mr. Kumar, who will be my candidate who's agreed for examination of his spine. Are you fine with me examining your spine? Okay, thank you so much. So regarding the spine examination, here I'm not going to cover much on the history, but again that makes a different value. A detailed history for the spine, starting from the duration of pain and the region of involvement mainly, and is the pain radiating or non-radiating? Is it acute, chronic? Is there any exacerbations in between? What are the causes of exacerbations? Starting from the type of work, lifting, coughing, which is mainly towards the discogenic pathology and other things like that. And any indirect symptoms or features of neurological involvement or even infections, being an unsteady or not able to do his work and different things. And so starting with the spine examination, as good and important, I always start with the gait of the patient. Can you please walk and show? Yeah. So a good steady gait that the patient is going to carry us through shows that he doesn't have much of neurological involvement. Can you please stand? Stand. Yeah, thank you. So after going through a quick analysis of the gait, starting from the examination, as not only having a look at the back of the spine, even from the front, we can see the symmetry of the body, because comparing from the bilateral shoulder symmetry, any wasting of the muscles, which again gives us a great importance of neurological involvement, and also the upper limb, any evidence of wasting on the upper limb, and also on the lower limb, how does he stand, is there any deformity involving the foot or the hand and other things, and making him to turn back, which is again very important. Starting from the inspection point, asking him to stand erect, we tend to see a very clear view on the erect positioning or the centering of the head over the body, and also the bilateral shoulder symmetry, whether they are at the same level, the contour is maintained, and any evidence of wasting of periscapular muscles. And also we get a clear view on the kind of the normal lordotic and the kyphotic curve that is involved, the cervical, the thoracic and the lumbar lordotic curves, whether it's exaggerated or, again in this case it's better to strip the patient entirely out to see that, but for the convenience of the patient I'm not doing it here. So again, it gives us a clear view whether there's exaggerated lumbar lordosis or exaggerated kyphosis, which again gives us a clue onto which we are looking at for the patient. And also indirectly making him stand lateral gives a clear view on not only the normal three curves, the cervical, thoracic and the lumbar, and also the pelvic tilt and obliquity. If the pelvis is tilted or more to maintain the sagittal balance, it gives a clear view. If there's kind of a listhesis because of the sagittal imbalance, the pelvic obliquity goes exaggerated. And second point, again I make the examination, I run the fingers through the center of the spinal process to see any, that gives a clear view on if there's any alteration in the exaggerated curve, one thing, or any increased distance between the spinous process. And also going across, palpating the paraspinal region, and also looking for any twist or Halsworth step is again trying to kind of give a twisting force to the spinous process to have any, look for any tenderness. Again we can go palpating the interspinous spaces to look for any tears in the interspinous ligaments. Again, the final point being the thirst examination for thirst tenderness, which again will be positive in number of spine pathologies, including the intervertebral disc prolapse and also listhesis and other processes. Again, having a classical midline tenderness points towards a central kind of disc. The next examination will be to look for the spasm of the paraspinal muscles, which is again very clearly evident. Again, when we strip them and see, the normal contour will be lost and the turgor mass running on either side of the spine again is very evident on that. Before going to the other examination, I quickly go ahead to finish the normal range of movement of spine. That's very important. I start with the Schober's test, or looking for the flexion. Ideal Schober's is like we examine for the bilateral posterior superior iliac spine, draw a line, and from that we take around 5 centimeter first mark and 10 centimeter, make him flex on a measuring tape and then examine. But normally we just see how far he's able to flex. Flex, yeah, thank you. So there's a good amount of flexion here. Extension, yeah, extension is good. Yeah, that's fine. And again, lateral bending, yeah, and also going for the rotation of the spine, yeah. There's no pain and it's comparable on either sides of the spine, so it's perfectly fine. So this would give a very clear idea on the overall examination of spine, and also to look any evidence of wasting on the posterior aspect of muscle. There isn't any. We have examined palpation wise, we have seen the same. I think the next step in spine will be going to the after inspection and palpation will be going to the special testing. Could you please write down? Because again, one of the important point on examination will be the scoliotic curve, if there is any, especially adults and people or even adult people, if there is any spinal scoliotic curve. Again, we have to see where is the primary curve and the secondary curve. In that, which would help us is the bending forward, Adam bending forward test, wherein the other secondary curves tend to disappear and the primary curve tends to be maintained, and also it helps in differentiating between structural and non-structural scoliotic curves. Okay. So the commonest pathology being the intervertebral disc prolapse. Again, a good neurological examination and kind of nerve stretch tests are very important here. Again, after making him lie down, it could be at the level of the lumbar spine, or it could be at the level of cervical spine. Starting with the lumbar spine, I make the patient turn to one side. Thank you so much. Again, quick run for thirst examination to pinpoint the level of tenderness. Usually it's the L4, L5, commonest discipline here. And also to see for bilateral posterior superior iliac spine region that again marks to a tenderness of sacroiliac joint. So I quickly carry out the nerve stretch test, starting from the SLRT, the straight leg rising test, which is again a very passive test. You don't make the patient do that, and you keep doing that. So in this case, he's able to do till almost till 90 degrees. So normally, if he starts having a pain at that region, for example, usually it should be having pain and not be able to do more than 30 to 40 degrees in cases of disc prolapse cases. So once we reach that point, we just decrease 5 degrees and then go with increased dorsiflexion, which causes increased stretch of the nerve. Again, shouts with the radiating sciatica line. These are basically the sciatic nerve stretch test. So the SLRT and a little bit modification on the endpoint of that, we look for the ankle forced dorsiflexion. The other test again which we can do for stretching is the bowstring test, where we flex the hip and the knee to 45 degrees and then give a bowstring here posteriorly, especially over the popliteal fossa, and then go for forced dorsiflexion of the ankle. Again, we tend to compress the sciatic nerve cords, causing the symptomatic sciatica features that the patient enlightened to you. Apart from this routine examination of the hip and knee, we go for the neuromuscular examination, checking for the power of the hip flexion, extension, knee flexion, extension, and ankle. I'm not going to do it in detail because it covers a quick dermatome. Hip, especially the flexion, covers L1 and L2. Knee extension, when we make the patient, can you just extend? Yeah. Push the extension is for L4, L3, L4 mainly, and ankle dorsiflexion, the side please. Ankle dorsiflexion is for the side. Yeah. So ankle dorsiflexion again, L4 mainly into L4, and also I go for great toe extension, that is L5. And for plantar flexion, we check the power of S1. There's a quick analysis on the thing, and also I do a quick sensory examination on either side with pinpoint dermatomes being the first wave space being classified for L5 and lateral side of heel and zone being S1, and L4 again the dermatobal map from the thigh. It starts with L1, L2, L3 and L4, L5 region. So this could be the sensory mapping here, and also checking for the intent reflexes. You need to have a knee hammer, and we check for mainly two reflexes. One is the knee jerk and the other one being the always try exposing the thigh of the patient to see the contraction of the quadriceps. Yeah, just you can loose. See, it's a great jerk there. So this is for the knee jerk, and the other one being the ankle jerk, checking for the contraction of the gastrosoleus muscle. So this is going to apply for your L4 nerve root, and mainly your ankle is for S1, so L5 doesn't really have a good reflex to check on with. So apart from this examination, we also look for the other joint involvement, quickly for the hip joint. Any rotation restriction, any pain on the flexion? No. So it's going to be effective. And also we have a look at the SI joint, which is the figure of 4, the Faber's test. We give a compression test. We see no pain, and also we can pull the patient a little to the side. Yeah, the side please. Yeah. And also we can do something called the Gansler's test this way, taking it for extreme hip extension and checking for the pain on the sacroiliac region. That's again negative here. And I think this would give a clear view on the lumbar spine examination and neurological assessment, and also a similar neurological assessment for the neck if there is intervertebral disc involvement, starting with the shoulder, the deltoid abduction, checking for the power, elbow extension, power and flexion power, and wrist and hand grip. You just grip me, you must. Yeah. So overall, the patient is finished with this. The flexion, please. And do the movement, all movements are good. So we need to have detailed examination, either starting from, this is going to be the C5, C6, C7, C8 and T1 dermatomes, respective movements. And also we have a quick examination of sensation again on the dermatomes, and the reflexes basically we see on the biceps jerk and also the triceps, and one other being the supinator reflex. That is really important for the cervical spine examination. I'm not going to detail neurological examination, just to give an overlay of the neurological examination of the spine. And the other things, I think I've covered the topics. And again, routine distal neurovascular examination. I think in our part of the country, we should also keep a clear view of tuberculous involvement of the country, of the spine, especially in India. So we also examine for any deformity of the spine, Gilbert's and knuckle deformity, along with the neurological examination, because Pott's paraplegia is again really common in India, which is on a reducing trend, but we need to keep an eye on that. Thank you, Mr. Thank you.